Okay, let's shift our focus now to schizophrenia. This is another chronic condition affecting many Australians. Our sources highlight something interesting. While ideally managed in partnership with specialist services, the reality is many patients with chronic schizophrenia end up being managed solely by their GP, often due to issues with specialist service access or patient engagement. This really puts a lot on your plate.
That's precisely it. Your role in monitoring and managing their physical health, alongside keeping an eye on their mental state, becomes absolutely paramount in those situations. People with schizophrenia have a remarkably high burden of physical illness. Up to 90% have a chronic physical condition. And there's a significant 2 to 3-fold increase in mortality compared to the general population from suicide, yes, but also from accidents and just common medical diseases. Conditions like obesity, smoking rates are incredibly high, diabetes, hypertension, metabolic syndrome. They are all 1.5 to 5 times more prevalent in this population.
Wow, those statistics are stark. Given that heavy burden, what are the key physical health parameters GPs really need to be monitoring? And how frequently? It sounds like quite an extensive list.
It is comprehensive, but it's entirely within a GP scope. These are things you monitor regularly anyway. You'll definitely be familiar with the general metabolic checks: weight, waist circumference, blood pressure, fasting glucose, and lipids. These are crucial given that higher prevalence of diabetes and heart disease. Beyond that, there are specific considerations often tied to the antipsychotic medications themselves. Things like monitoring prolactin levels, because some antipsychotics cause hyperprolactinemia, which can lead to things like menstrual irregularities or galactorrhea, and annually checking ECGs, specifically looking at the QTc interval, as prolongation can indicate a risk for serious cardiac arrhythmias. This risk varies between antipsychotics but needs monitoring. Our sources detail specific recommended frequencies for each of these checks, really highlighting why this proactive physical health approach is so vital and genuinely life-saving for these patients.
So, when you identify these physical health risks during monitoring, what does this all mean for actually managing them proactively in the practice?
Right. Well, diet and exercise advice are absolutely essential baseline interventions. Consistent encouragement and support. Pharmacologically, metformin is often favored, sometimes even prophylactically, to help prevent or manage weight gain and hyperglycemia associated with some antipsychotics. Statins for abnormal lipids, as per standard guidelines. Now, switching antipsychotics to one with less metabolic risk, maybe like ziprasidone or aripiprazole, is an option, but it always carries a potential relapse risk that needs very careful consideration and discussion with the patient, and ideally a psychiatrist if possible. For movement disorders like tardive dyskinesia or Parkinsonism, dose reduction or a change in medication is often necessary. And don't forget dental health. Many antipsychotics cause significant dry mouth, xerostomia, so patient education on meticulous oral hygiene is incredibly important to prevent cavities and gum disease.
And thinking about the pharmacologic side again, beyond just the monitoring aspects, what are the key distinctions GPs should be aware of when considering the antipsychotic medications themselves?
Yeah, antipsychotic medication is truly the cornerstone of treatment. They primarily work by blocking dopamine D2 receptors in the brain. The atypical or second-generation antipsychotics are most frequently used today, but they vary quite significantly in their side effect profiles. This really impacts your choices around things like weight gain potential, risk of extrapyramidal side effects, those movement issues like tremors or stiffness, hyperprolactinemia risk, QTc prolongation risk, and levels of sedation. It's really about tailoring the medication choice to the individual patient's needs, their existing health risks, and their tolerance for specific side effects. It's also worth remembering that depot antipsychotics, the long-acting injectables, are available for both older and newer atypical drugs. These can be absolutely invaluable for improving adherence, which is often a challenge.
What about the non-pharmacological support? And also this concept of recovery in schizophrenia, which can sometimes be misunderstood.
Well, your continuous care relationship as a GP forms an excellent foundation for providing supportive psychotherapy, helping with practical problem solving, and giving ongoing lifestyle advice. For patients who might have cognitive deficits, which is common in schizophrenia, simply writing down instructions clearly can be remarkably helpful for them. Specific psychological treatments like cognitive behavioral therapy for psychosis, CBTP, can also be beneficial, particularly for addressing persistent symptoms like distressing auditory hallucinations. And critically, yes, the recovery paradigm. This emphasizes the patient's own self-defined pathway towards restoration and a meaningful life, not just focusing solely on symptom resolution or elimination. It's about fostering a collaborative relationship where you are the expert in medicine, absolutely, but the patient is acknowledged as the expert about themselves, their experiences, and their goals. It fosters hope and empowerment.